I will be talking about really how FDA law, in particular around advertising, is being disrupted through the Trump-Kennedy administration. And maybe that tells us some lessons that we can apply more broadly. Um, so let me start with this um, quotation that we get from Robert Kennedy himself that I think kind of tells us the gestalt or the times we're in. He says that the pharmaceutical ads hooked to this country on a prescription drugs. We will now shut down that pipeline of deception and require drug companies to disclose all critical safety facts in their advertising. Only radical transparency will break the cycle of over medicalization that drives America's chronic disease epidemic. Here, the suggestion is that disease is caused by drugs rather than drugs, treating disease. And and this was said just a few weeks ago, actually. This isn't some, radical statement of an activist. This is from the Secretary of Health and Human Services. And so I'm going to talk about how this worldview is impacting their approach to drugs in three different areas. And the first is direct-to-consumer advertising. Um, we spend a ton of money promoting drugs in the US, $23 billion by a recent FDA count. And about three-quarters of that is actually promoted through healthcare providers, right? That's detailing, showing up in their offices, going to their national conferences, publishing in their journals, sponsoring their professional societies. And I think that raises a lot of problematic questions. But frankly, a lot of scholars and critics are more focused on the 28% of the spend that goes directly to consumers. Now, if you look around the world nationally, globally, if I was doing this as a class, I'd call someone to guess how many countries allow any direct-to-consumer advertising. And the standard answer is there's actually only two, the United States and New Zealand. I think in practice, you'll probably find some ads in sub-Saharan Africa and other places where the regulation is perhaps not as tight, but at least in terms of overt permission, where it's widely done, it's these two countries. So the U.S. isn't something of an outlier in this regard, and I'll talk a little bit about the constitutional values that might explain some of that. But first, I also just want to explain how this is a very, very large business. This study is now a little bit dated, but you can see the increase in advertising over time. And this is really predates the explosion of social media. Television advertising, and at that time, newspapers were the two largest sectors. But now social media influencer marketing dominates as well. But even if you just look at the type of television that's now called linear television, where you watch from beginning to end instead of streaming and selecting your own shows, about 13% of the entire budget on, Fox News or ESPN is paid for by the pharmaceutical industry. So it's really a part of the American structure of media. And there's been lots of research on what sort of drugs are targeted and what are the effects of this approach. Chris, I see your hand is popping up. Let me know if you have a question. Feel free to jump in, but otherwise I'll just run to the end, and we'll have question Q&A at the end, I understand. So
Yep.
in this study, for example, from DeFestano and colleagues in JAMA in 2023, they studied the 150 best-selling drugs and they rated each one as to their clinical benefit. Was it low clinical benefit? And these are using national ratings from countries like France and Canada that actually use clinical benefit as a proxy for how much they're willing to pay. Bottom line they found is that most of the drug spending or more of the drug spending was actually aiming at the lower benefit drugs. And that can kind of make sense, right? There's an old saying that a quality product sells itself, right? If a doctor knows that this drug is really powerfully beneficial, they'll prescribe it anyway. So it seems that the industry recognizes this and is using advertising to lift some of its, less attractive drugs that don't really have a huge benefit. Maybe just another follow-on in a tight space. or where the benefits are not strongly proven. And of course, these are all FDA approved drugs. They're proven to have some benefit, but it's more or less here. And this is a study from Alpert and colleagues that looked at the change in prescription drug spending after Medicare Part D was launched, and that caused a shift in advertising to zip codes where there were more older people, in fact. And that shift was allowed the economists to then figure out how much of the change in spending was due to the drug advertising growth. And they found it was quite substantial. 31% of the change was due to advertising. And some of that was actually just people switching brands because they saw the brand on TV without actually getting any health benefit. So for these kinds of studies, which I've just given you a very small sample of, has led to a consensus, I would say, that we've seen over the last decades of the AMA saying that they should ban all advertising. The WHO says it should be prohibited. Major journals, major commentators like Green and Kesselheim, Public Citizen, APHA, everyone seems to think direct-to-consumer advertising is like the voice of the devil. It's only causing problems in our healthcare system, driving lots of expense without much health benefit. I would just linger for a moment, though, and suggest that it can actually cut the other way as well. And if we do remember that all these drugs that are being marketed are proven safe and effective to the satisfaction of the FDA, we can talk about whether they should have higher or lower standards. But using that as our proxy, it's curious that we think that it's problematic for people to decide they want to consume one of these products that's already been FDA approved. And there are cases like statins, for example, where we know that not as many people that need statins are on them or stay on them. There's a real adherence problem in the US as well. We know that not everybody that needs vaccines are getting vaccines. And it's really striking to consider that the leading cause of death in America is obesity, 2.8 million. I mean, it dwarfs handguns by, several orders of magnitude. It dwarfs tobacco and alcohol and anything else. And we now seem to have this wonder drug or drugs in the GLP-1s. So it's at least possible that we actually think that in some settings, direct consumer advertising might be worthwhile. So like, for example, for the flu shot, the federal government itself does advertising, encouraging this. It's a little odd if we think that companies that stand to benefit from this are unable to say exactly the same thing that we, the government, or we, our own employers, might say. So I just want to suggest it's a little peculiar to be so unanimous in thinking DTC is a bad thing. And this is a graphic that I made with the help of Gemini, Google's large language model, just to remind us that before a drug can get to a patient, right, it has to clear the FDA as safe and effective, as I've said. These are prescription drugs we're talking about, so it also has to clear a physician. They have to decide that its benefits outweigh the costs for you. And frankly, the insurer provides a third sort of gate that a drug has to pass through. And then, of course, we also use copays to discourage patients from consuming. Against all these gatekeepers that ended up in consensus that this would be a good drug for the patient, we nonetheless want to prevent the patient from hearing about it in the first place through direct-to-consumer advertising. So you can see I'm a little more equivocal than some about this potential regulation. But nonetheless, there's a robust regulatory framework. It goes back to the Food and Drug and Cosmetics Act. Section 352 in says that you have to, if you're going to advertise a drug, have to include a brief summary of its effects, its contraindications, and its side effects. And for a little while in the 1980s, the FDA sort of encouraged and it worked to get a voluntary moratorium on broadcast ads. Lasted for a few years and it was rolled back. And then there was a rule now since 2009. Congress encouraged this rule that we could allow a company to have a broadcast advertisement or other sort of attractive, visual, concise advertisement that doesn't necessarily list all the risks in detail, as long as it directs you to some other place where you can find all these risks. So back in the old days, that was like, see our ad in Prevention Magazine or in Men's Health Magazine, see our ad there. And then the ad would have all the fine print, sometimes thousands and thousands of words about all the various risks that you could just refer to people. Now, of course, websites serve that same purpose, and we do have an office in the federal government that supervises this framework. But here, just in the last few weeks, the Trump administration turned that all on its head. And it was interesting. The president himself wanted to get involved in this. Sometimes the agencies do things, but the president wanted his name on this because so he instructs the agency to do this. Around the same time, the FDA commissioner, Macri, releases a viewpoint in JAMA calling this a crackdown. And this is really the first sort of systematic campaign against direct consumer advertising in nearly 20 years. On that same day, this was on September 9th, 2025, the FDA announces that that day it's releasing thousands of letters, including 100 that are specific cease and desist letters, as opposed to just warnings or concerns. And it says it's going to make a rule to eliminate that provision for adequate, that rule that says you can put the risks somewhere else as long as you make that as an adequate provision of the information. The FDA calls that a loophole that it's now going to close through new rulemaking. And so I just want to sort of flag the First Amendment constitutional issue that's here, right? Um, the Supreme Court has for decades held that commercial speech is itself protected by the Constitution, but it had said in the Central Hudson case that it's maybe a lower level of protection. It doesn't get the full strict scrutiny that you would apply to other regulations of speech. But more recent case law, like the Sorrell decision that involved prescription drug data, the court was sort of suggesting that commercial speech is fully protected. And of course, just yesterday, in the sort of analogical parallel domain of professional speech, the court seemed quite hostile to the idea that the state had a special ability to regulate when it's a healthcare professional or a mental health therapist. So they're really the larger trend we're seeing in First Amendment law is reducing or eliminating these special zones where the First Amendment has less force. So to the extent the Supreme Court maintains this sort of approach when the FDA's current new attack crackdown is litigated, we might see them being quite skeptical of this crackdown. But nonetheless, it really is only a rule, at least as it's been described and implemented so far. It's really only a rule that you have to fully disclose something. It's really just a disclosure mandate. And that sort of reminds me of Congress's decision in 2009 to empower the FDA to require graphic warning labels on tobacco. And that has been litigated for over a decade now. And ultimately, the First Amendment claim has survived. It even survived in the Fifth Circuit. And so we still don't have graphic warning labels because there's administrative law objections. But this suggests that at least a full disclosure mandate might survive because it's not a ban on speech. It's just saying you can speak, but we're going to require you to do this completely impractical thing of disclosing thousands of words in the advertisement itself about the full risks. And so that's really that second question I'm posing here is like, is this actually a backdoor way to eliminate direct-to-consumer advertising if they make it infeasible, or at least broadcast advertising, or quick social media advertising, if it's infeasible to give that complete list? And if that happens, I imagine this will actually drive more advertising, more of the major media that's expensive media that has to be journalist and produced. It's going to be another cut to their bottom line, which might be in the interests of some political groups. So last thing in this section, I want to just ask, given that everyone was hating on direct-to-consumer advertising, should we expect to hear, 3 cheers for Trump Kennedy? Wouldn't it be nice to find something that you agree with in this administration? It's sort of a test of our own objectivity as scholars and as organizations. So far, nobody has really spoken up very loudly in favor of this Trump Kennedy decision. It's kind of like crickets out here. But maybe, it takes time for organizations and speakers. Some, like Aaron Kesselheim, was quoted in the Boston Globe saying this is an evidence-backed policy. But we'll see if others come to applaud Trump Kennedy on this one front, or if they've just sort of lost all credibility with science-based organizations. So even when they do the right thing. So I'll speak a bit about two other areas. This is on compounded drugs. I want to flag, I'll be referring back to these GLP-1 drugs again and repeatedly. They really are a landmark transformation. And this is one of the advertisements from Novo Nordisk about their own product. And I just want to flag up here on the top left, that is the indication that's approved by the FDA. So this would be an example of an on-label advertisement. And you notice, right, there's not much room to list hundreds and hundreds of words about all the various rare risks and non-rare risks. But in addition to this example of an on-label marketing, we've also seen, and before I go back, I mean, look at the specific indication. It's for adults with type 2 diabetes and known heart disease, a fairly small population compared to the 2.8 million people that die each year due to obesity, because that it just haven't been tested and approved for the larger population. But we have these other companies that are doing direct to consumer marketing of telemedicine saying, just go to our website, we'll get you hooked up. Notice how they're promoting it for broader uses. They're promoting it essentially off label. And I'll talk in a minute more about that off label aspect to it in my third section. But it's striking that this is a quasi independent company that's selling not just Ozempic itself, but a compounded drug that's made to be very similar to Ozempic. Here's another example from Weight Watchers saying that they're going to treat obesity more broadly, and then Hims and Hers really broke the camel's back by actually going on the Super Bowl and advertising to millions of Americans their GLP-1 compounded alternatives as well. And so this got everyone's attention, I think, and they were like, whoa, this isn't just some back corner of the internet. We now have this major advertising. And just as an aside, I'll mention that to me, this felt very similar to the moment when all of us nerds were talking about direct-to-consumer genetic tests. And we were like wringing our hands, what are the different companies going to do? And then all of a sudden, 23andMe just goes and buys an ad at the Super Bowl. This was now about a decade ago. And similarly, that ad caused the FDA, who was kind of slumbering, and they were talking to the nerds like us and going back and forth. Eventually, the Super Bowl ad got the FDA's attention, and they started cracking down on the sort of health claims that 23andMe was making as a medical device, interestingly, in that context. So anyway, Hims and Hers really got the attention, I think, of everyone by advertising for the Super Bowl. Now, what is compounding? I think the paradigm example is where, your kid needs a drug, but they can't swallow the pill. So you go and ask the pharmacist, could you like give me it in a liquid form instead, even though the manufacturer doesn't sell it in a liquid form. And the pharmacist will, in some cases, literally grind it up and remix it into a solution. So you have, cherry flavored medicine for the kid. That's the paradigm example. It's supposed to be cute, kind of bespoke, kind of rare, and pretty safe because you're literally just grinding up drugs you already know exist. But in fact, it varies quite widely, and the regulation has some federal aspects, but is largely dependent on states because it's considered the practice of pharmacy rather than the sale of a product in interstate commerce. But it's actually become pretty substantial. It's 1 to 3% of all prescriptions, over 600,000 claims in an insurance database, one of the major studies. A review by the Pew Foundation found that there were 1,500 adverse events, 116 deaths linked to compounding drugs. And there was this huge meningitis outbreak in 2013 where meningitis was spreading into a contaminated lot that was then compounded. In all these blue states, there were people injured and 64 people died. So compounded drugs have this sort of shadow behind them. But nonetheless, it has been a way for a lot of people to get access to these GLP-1 drugs through a rather unique provision of patent law, an exception in the innovation environment that Rachel could probably tell you more about than I can. Because federal law has this exception to patent law that I have here in the last bullet, where there's shortages of a drug and you're compounding in order to fill that shortage. And there were, in fact, shortages of the GLP drugs for a while. But the federal law says you can nonetheless, if you're advertising compounded drugs, you can be in trouble if they're false or misleading. You can also be in trouble if you're using components that aren't on this FDA list of bulk drugs, or if you're using the exact same thing as an FDA approved drug, but aren't subject to this exemption. And so in 2025, FDA cracks down. Again, this is just a few days ago, a couple weeks, and they send 40 plus warning letters, half dealing with GLP-1s, some of the companies I showed you, and they're saying that these are deceptive ads, they're misleading, where you say it's the same active ingredient as Ozempic. The FDA says, no, actually, you're using a salt version of that same active ingredient, so it's not the same. When you invoke a brand name like Ozempic, you're actually implying that there's FDA approval, but the FDA hasn't inspected your manufacturing, or we don't know if it's actually equivalent, and if you're advertising without those same safety risk disclosures. So as I move on from this second of my three areas, I want to just flag that, this crackdown is really in the interests of the big pharma. So it's kind of interesting to see Kennedy's doing a favor to Novo Nordisk and Lilly, two of the biggest makers of brand name GLP-1 drugs, because the compounding was really cutting into their potential profits. And so it's we see Kennedy maybe throwing them a bone. Okay, so the third area I want to talk about briefly is off-label promotion. This really goes back to the FDCA and the way it defines even what a drug is. We have all sorts of chemical compounds around, but it's only a drug if the seller of it intends it to be used in diagnosis, cure, mitigation, treatment, or prevention of disease. That intention is what then makes it a drug, which then triggers the requirement for pre-market approval, proving it safe and effective. And then a drug under regulations and statute becomes misbranded unless it contains all the instructions you would need for all the intended uses. So you work backwards to ask, well, what did you intend it to be used for? We then have to put them all on the label and prove them all safe and effective and give instructions for how to use them. And so this legal regime creates an interesting system where firms that sell drugs can only promote them for their labeled indications. Because if they then say there's some other indication that they start promoting for, that shows they intended that other indication, which makes the drug misbranded, which makes it a crime to sell it. So the firms end up being forced to stay on label by this intended use principle I showed you on the last two slides. In contrast, since the FDA doesn't regulate the practice of medicine, physicians can still prescribe drugs off-label. And this is sort of the balance we get between evidence and innovation. This balance was really disrupted, though, in 2012 in a case called U.S. versus Cronia that can overturn a conviction for some pretty egregious off-label marketing by a company of a pretty dangerous drug. And they said, hey, you can't prosecute him for what he said as long as it was truthful and non-misleading, which really drove if a lot of us in this world were of the nerds that are following this were really kind of stunned because the speech was not actually the crime. It was just evidence that it was a misbranded drug because of that intended use principle we just talked about. And the court basically just ignored that principle. But this is a case where the FDA actually didn't, or the DOJ didn't actually appeal to the Supreme Court, probably a little worried that they would get a decision that, sort of broadened the application of this awkward loss in the Second Circuit. So this area of law is still a little precarious. Nonetheless, we know that off-label uses are very widely used. For example, these GLP-1s, over a third of the uses are off-label. That's largely because many of the indications aren't for weight loss at all, or if they are, it's only for people with higher BMIs over 30, obesity. More broadly, we know that about 12% of prescriptions are written off-label. For if you write a prescription for a kid, for example, in pediatrics, it's very often off-label. Psychiatric uses, cancer uses, all over the place. And studies of this have shown that most off-label uses really lack strong evidence. They're sort of doctors making guesses. And the evidence also shows, so that's 81% of the time, it's just doctors guessing. And we know that in those cases, you're much more likely to get an adverse drug event. It hasn't been studied in a large sample, like as the FDA requires, that would show you whether it has risks or not. We don't know the drug interactions and all sorts of problems when it's off-label. So this is an area of concern. So what is Trump Kennedy doing on this front? Well, it turns out that almost nothing. And I went ahead and kept this in the talk because it's, I did spend some time researching to find out, is this part of the agenda? And I think the nothing side or the all is actually quite interesting also, that this is not a space, even though the evidence would suggest it's a problem, it's not a space where Trump and Kennedy is focused. Why not? Well, I would say that's because Kennedy himself has really hitched his wagon to some off-label uses, in particular of ivermectin and hydroxychloroquine during the pandemic. And he says that trying to restrict use of these is the FDA's war on public health that he's now ending. So you might recall from the COVID, we almost forgot that, while Trump was so excited to be bringing out these new vaccines, Operation Warp Drive. Again, if we're going to applaud something, we should applaud Trump administration, one, for getting vaccines out into people quickly, even though he bad talked them a little bit later. Huge life-saving public health effort by the Trump administration. But at that same time, Kennedy was doing the opposite. He files a citizen petition asking the FDA to withdraw its emergency use authorization. And the reason why? He says, you don't need vaccines. You can just use ivermectin and hydroxychloroquine, both as treatments and as prophylactics. So it was really central to his anti-vaccine attack were these off-label drug uses. You might recall that hydroxychloroquine is actually only approved for malaria, and the contemporaneous research at that time, as well as larger studies looking back, have generally found it had no benefits to coronavirus patients, and it actually did, in some cases, prolong their illness and cause heart problems. Likewise, ivermectin was approved for parasite infections. It was used at very, very low levels for many years. And then when COVID happened, it explodes, 5 times increase in use. People are calling poison centers and severe toxicity. It was pretty gnarly. So when I said that Trump Kennedy is doing nothing on the off label, I said almost. And let me tell you the one thing they are doing. Can you guess? Well, this is it turns out this is one of the tools in their toolbox when they're cracking down on transgender care for children in particular. Pam Bondi has instructed the Department of Justice to decisively protect our children and hold accountable those who would mutilate them under the guise of care and undertake appropriate investigations by manufacturers for any off-label uses of puberty blockers or sex hormones or any other drug used to facilitate a child's so-called gender transition. That's a quote, of course. So they haven't forgotten that this law is out there. It's a tool in the toolbox, but I haven't yet found any actual prosecutions on that theory. So that's the sort of framework of the 3 areas that I wanted to discuss: direct-to-consumer advertising, compounding, and off-label. I'll be delighted to have your questions both in the session, and I'd love to get an email. Hear from you if you have related work or anything else I should hear about. Thank you.
Thank you very much, Professor Robertson. A reminder to the audience, if you have questions, to include them in the Q&A section, and we'll come to those questions at the discussion part of this presentation. I'll turn it over now to Professor Sachs.